Dr. Aimie, it's so great to have you on DHA's webinar series. We are so honored to have you talk about trauma recovery, and we really value the work you're doing in the field. And I know my provider list is so excited to hear from you. And I'm not going to talk any further, but I do want to know how you got into this work and just a little bit about your background, because I know you can speak to that much better than I.
It's been fascinating to see how much these biochemical imbalances and how much the biology piece has been a big piece of my trauma journey, and one that did not kind of coexist at the beginning, but has definitely become a big part of it. So I was in medical school and I had just finished a master's in biochemistry. And I decided to become a foster parent in the few months that I had in between there. And they placed 4-year-old Miguel with me. And by the time he was turning 5, I had decided to adopt him in order to get him out of the foster care system where he had not had a great experience. And through that, and as a result of that, I went on to work with over 100 adopted children from around the world, from hard places like China, from Russia, places where, because of the care that they provided early in life, the children had significant neurodevelopmental gaps. They also probably had malnutrition and a number of biology factors, but it created this storm effect inside of their body where they were having a very hard time accepting and loving their new adopted parents. And that's why their parents would come to my camps that I set up, was to help with that attachment that just was not happening. And I did all of this still without any of this piece around the biochemical imbalances and labs, because all I knew were the parenting things and the regulation things that I had been learning with my own son, Miguel, and that attachment and bonding. And it wasn't until I got sick that the biology piece became center and front for realizing that that was what was holding me back in my ability to do trauma work. Let me explain. I started with a general surgery residency. I did 4 years of general surgery residency before deciding that I needed to switch out of that. But during that time, just at the end of my 3rd year of general surgery residency, I reached a burnout that I had never had before. And what that looked like was I was already on 2 mood medications, diagnosed with depression, anxiety. We don't know. We're just going to call it burnout. And they had started me on Zoloft and Wellbutrin. And I was easily 30 pounds overweight from what I am now. And I had been developing chronic fatigue, but had been figuring out strategies to push through until one day I couldn't push through and I couldn't get out of bed. So I went on a medical leave, and that's when we did labs and found that I also had autoimmunity. From there, conventional medicine, my field, didn't have any answers for me. And that is how I found functional medicine. And from there, I found Dr. Walsh's work. And as I read Nutrient Power, I saw myself in many of the descriptions of the biochemical traits. I did not do much with it at the time because all of that functional medicine stuff was so new. And I had a few other pieces that were screaming louder, like brain inflammation. I had a significant amount of brain inflammation. And so I started piecing together what I needed to do, because what would happen is that when I went in to do trauma therapy, I would experience a crash in my health afterwards. So I would go into trauma therapy and we'd have this, what I thought was this great session at the time. And I'd probably cry a lot and release a lot and probably talk a lot about the story. And then I'd come home and I would just crash. And I would wake up and my body would be worse in the inflammation. And my gut would be even more off. And the fatigue would last for several days. And I realized then, as I even started my own training in different somatic and trauma therapy modalities, that my body was what was holding me back. My body was burdened down with something, and I needed to go figure it out. And coming out of a car accident, where I wasn't able to bounce back, that was when I really started to take the biochemical imbalances seriously. And at that time, I finally did testing and I discovered that I had all three. I am a strong undermethylator, I had pyroluria, and I had a significant copper excess.
Wow.
So things started to make sense for me. And from that moment on, I have started to approach my guidance of other people on their trauma healing journey differently, because I know how big of a role biochemical imbalances can play with a person's stress and trauma response when they not even know it.
That's an amazing story. I've honestly never heard it before. I've known you for a couple years, and you're absolutely right. I mean, it's the foundation of almost everything, right? Is our, nutrient status and paving the way to our neurotransmitter balance. And I too picked up Nutrient Power one day years ago, and I read it and I read it again, and my life was totally changed. And I couldn't believe that I missed this book. Like, I had been studying for years and years, and I had become a functional medicine practitioner 3 years before. And then all of a sudden I discovered Dr. Walsh's work, and I'm like, oh, this is why I'm like this. So I'm right there with you, and we want to hear more. We want to hear how your clinical insight and how you're specifically looking at these cases and how you're healing their biochemistry, because as you say, it's a huge part in, the healing from trauma. And I can't wait. So I'll let you get started, and thank you for being here again.
Thank you so much. I'm really excited. And what I want to share and what I want to start with is really the body's trauma response. And until we understand that and the actual physiology and the neurobiology that's happening, we won't understand the significance of the biochemical imbalances with the body's trauma response. So let me just start there and walk you through the body's trauma response. And I have mapped this out in a way that if you are a very astute practitioner, you will recognize this graph as Dr. Hans Selye's graph on the adaptive response of the body. But he didn't have language back then to distinguish stress from trauma. So he called this chronic stress, where I'm going to call it the trauma response. And here's what's happening. Let's say that we start in ventral vagal parasympathetic. My word for that, after my years of trauma training now, is calm aliveness, where I feel connected, I feel curious, I feel creative, I feel secure, I feel safe, all is good. And then I'm going to have a startle moment. And that startle moment, you can see in the graph, it's the upregulation of the sympathetic activity. And with the sympathetic activity, the neurobiology of that is that adrenaline and noradrenaline start to get released. Now, there's about 15 seconds that we have in order to determine if what startled us is an actual threat. And then if we still don't know after 15 seconds, our sympathetic system will be like, well, if I still don't know, then it must be a real threat. And I'm going to go all the way. So to go from a startle to a stress response, we either have to confirm that, yes, there is a threat and a danger, or I still don't know, and not knowing is the threat and the danger. Either way, we're going to have the biggest upregulation of the sympathetic activity. So now there's even a larger release of adrenaline. There's a larger release of noradrenaline. Noradrenaline is pre-packaged in the vesicle, so it's ready to be made, and it's released immediately in the extracellular matrix and the tissues so that it can change the blood flow. It can start to change the mitochondria. It can make immediate changes and not have to wait for the adrenal glands to make adrenaline. But by the time adrenaline hits, we can feel our heart racing, we start sweating. And what's happening at the cellular level is very important, because it's what determines whether something will just be a stress for the body or if we will cross a critical line of overwhelm. Once we cross that critical line of overwhelm, then our body shifts into a different state of the nervous system. This is going to be the dorsal vagal response, if you are familiar with the polyvagal theory and Dr. Steve Porges's work. And now it doesn't matter how much adrenaline or cortisol you have. because the body's not responding to it since it has shifted its state. And that is where people experience first that freeze and then the collapse and shutdown, which our body will do in order to survive a situation where it doesn't think it can do anything else to survive. So let's talk through this, because that moment of the trauma response, according to Dr. Steve Porges, is perceived by the nervous system as an inescapable life threat. Whereas a stress will be a danger if our nervous system perceives it to be an inescapable life threat, then clearly the best solution is to shut down to save my energy. Bessel van der Kolk, author of The Body Keeps the Score, says that there are 3 qualities that make the body go into a trauma response. It has to be overwhelming to us. It has to be unbelievable. We can't believe what is happening. And it creates unbearable sensations in our body. Ones of loneliness, perhaps, ones of failure, ones of shame, ones of betrayal. And those sensations are so unbearable that we can't stay present. And that's exactly what the trauma response is. The trauma response is losing our ability to stay present to very uncomfortable sensations, including the upregulation of our energy, whether that's anxiety or anger with the sympathetic. And finally, Gabor Mate really defines that trauma as not the event. And this is what I would love for it to be one of the takeaway points for you from this, is that no longer do we want to be asking our patients what happened to you. We do not want to be focused on events. I'm even going to tell you, please don't even take an ACE score, because that focuses on events and what happened outside of someone. Whereas the trauma response is the feeling that happens inside of us. And that can happen every single day of our life. We don't need a big bad event to feel overwhelmed. We can't believe what's happening, and it's creating unbearable sensations within us. So homeostatic capacity is what actually defines a trauma response on a cellular level. Thankfully, because we are all familiar with homeostatic capacity from our background in training. So this is now familiar territory, and we can work with this concept more. So going back to the trauma response, as long as there is a stress and we are responding to it, that's not a trauma. And I don't care how big and bad the event is. If I'm able to respond, then it's just a stress. The moment that it becomes something so big that I can't respond, well, then I've reached my homeostatic capacity. And that becomes a trauma. So when I think of my mitochondria, I think of my mitochondria as having a certain capacity to make energy. And anything that is going to decrease their capacity to make energy decreases my homeostatic capacity, which means that that critical line of overwhelm is going to shift, and I'm going to reach that critical line of overwhelm sooner when my sympathetic system is activated. Whereas if I can buffer my mitochondria, if I can reduce oxidative stress, if I can resource it with zinc, with magnesium, with biotin, well, then guess what? My homeostatic capacity is now much larger, which means that I can hold and respond to more stress and it not become a trauma. And I'm not going to go into this aspect in this talk, but we do have the emotional aspect where our homeostatic capacity is actually greater when we have someone with us. When we are all alone and we feel all alone, our homeostatic capacity says, I must not be as strong. So actual touch and hugs and knowing that we have social support is a booster to our homeostatic capacity at a mitochondrial level. Let me go back to my slides, because we're going to now look at what happens with that homeostatic capacity. Here is the stress response. Inside of the cells, we have these mitochondria. And when we are faced with a stress, and again, I don't care what kind of stress that is, emotional, psychological, or a toxin, stress is stress. And the mitochondria, they change. They, in the words of Dr. Bob Navio, cell danger response researcher, they hunker down. So literally, when we have a stress, our cells, our mitochondria are like, hey, she needs us right now. Let's hunker down and give her our best. And they change shape so that, as you can see in this picture, it can upregulate the production of energy for me. Sometimes that's double the amount. When you think of having to sprint away from a dog who's chasing you, how much faster are you than when you just go for a jog? Well, yeah, it's significant, the difference. And why? Because your mitochondria are actually changing shape. They are creating different proteins. They're enabling the increased efficiency in the breakdown of glycolysis or the glucose in order for faster energy to be produced. This is why when we are stressed, it also is not possible for us to really even stay in ketosis, because our cells, our mitochondria are like, nope, that takes too much energy. That is too slow. I have to have fast energy. And so the more stress that we will feel in our life, the less successful we're going to be with a ketogenic diet. So also something to keep in mind if we are trying to navigate different things in our life and haven't been able to understand why we can't be successful with different things. But otherwise,
oh, sorry.
Yeah,
I was
no,
just
go
going to
ahead.
comment. I think that's so applicable to so many practitioners who obviously have full support, nutrition-wise, to their clients. And ketosis is stressful in itself, right? And it's just not applicable to every single person. And maybe not anyone, depending on how you look at it. So I love that point. And like, I'm enthralled by what you've said so far. I mean, 5 minutes in, groundbreaking. I already wrote down homeostatic capacity lowers when alone.
Yeah, this is all the mind-body connection stuff.
Yeah.
And there is lots of research on how the mitochondria, the immune system is actually stronger if you get 12 hugs a day.
Wow.
Wow. So our biology definitely is changed by social support and touch. We even know from studies from World War II that babies will die if they don't get touched. So touch should be considered an essential nutrient.
Wow.
And there are people in my courses. I'm thinking of Susan. She's actually a practitioner in my training course, and she has recently been diagnosed with breast cancer and was told that one of the things that might benefit her was to go on a ketogenic diet. And so she came to me saying, I am already experiencing a stress with this diagnosis. What am I supposed to do? Because I know the science, I know what you teach. And I said, look, a ketogenic diet, to be successful in a ketogenic diet, you just need to surround yourself with safety. Surround yourself with safety. So the body interprets cues of information. And in fact, let's go there. Let's talk about cues of information. So the overwhelm happens then with that critical line of overwhelm, so that this point here where we reach the critical line of overwhelm, it reaches that based on cues of information that it's receiving. So our nervous system decides the set point based on information from outside of us, information between us and another person, the biofield, if you want to bring that in, and inside of us. So our autonomic nervous system is amazing at being able to collect all of this information and distill it down to a simple equation. Cues of danger versus cues of safety. Which one weighs out? Which one weighs out? So that if we have a lot of danger and we have a lot of resources and capacity, well, then it's okay because I feel resourced and thus I have the capacity to respond to that size of the danger, like a diagnosis of breast cancer, like my partner and husband passing away, like and you name the problem. Those are huge problems that we might face in our lifetime. And as long as we have the cues of safety coming in at the same time, we're okay. But what happens is when we don't have the same cues of safety coming in, so that my available resources, my capacity feels really small next to this big problem in my life. And whether that's something right now in the moment, or whether that's something that's been happening my whole life, it doesn't matter. The size of the danger is always being weighed against the size of my resources and my capacity. So that when there's a gap, that will induce a response of overwhelm, which is trauma physiology. And I say trauma physiology because it lends our mitochondria, our cells, and our emotions to shut down and go into a collapse. And that is a whole body response. And when people describe feeling that way, to me, they use the words like, I'd like to go to bed and just curl up in a ball. That's how it feels. Now, whether we do that or not, that's not the point. Because most of us, especially as practitioners, we can't. When I was a general surgery resident, I couldn't go home into bed and curl up like a ball, even though I wanted to. I had to push myself through, which is why my body eventually said, we'll do it for you and we'll give you chronic fatigue, and then we'll lay in bed because we can't do anything else. So it's not a matter of what we do on the surface. That really is just the surface layer. It really is, how does a person feel inside? And so those are the kinds of questions that we're going to be wanting to ask our patients is, what does it feel like inside? And if they describe any kind of sensations like, I don't feel my body, well, guess what? That is a sign that they are in that chronic trauma state where they are disconnected. If you notice that they're sitting next to you and you're trying to explain a protocol and they are somewhere else, they are zoning out, their mind is wandering, that's a chronic trauma state. That's a state of disconnection. And I would use the word dissociation, where it doesn't feel safe to be in their body and to actually be present. And it's become a habit. Or, especially as practitioners, we see this a lot. They're coming in with health symptoms. They're coming in with health conditions. They're coming in with the chronic manifestations of their biology, going into this place of overwhelm and collapse and shutdown at the cellular level for so long that it's now showing up as symptoms. So that's where the biochemical imbalances start to really come in place, because I have experienced it both as a contributing factor to why we started going into trauma responses and the block to my nervous system getting out of a chronic trauma state. So let's take a look at that. The biochemical imbalances, let's just take copper. So copper excess, we know copper excess leads to increased adrenaline. Well, how is that going to affect my stress and my trauma response? What happens is that if my body is already creating adrenaline and then a stress happens in my day, I'm already closer to that critical line of overwhelm. I'm already in sympathetic activation. And so it's not going to take much more for my body to be like, okay, now that is too much. Whereas if I didn't already have that excess adrenaline from the excess copper, my body would be able to have a larger bandwidth, a larger capacity to be like, okay, let's do our best to respond to this. And so a copper excess already puts my nervous system closer to that critical line of overwhelm simply because of its effect on adrenaline. But it's not just that, it's also the effects on the neurotransmitters. So the biochemical imbalances can, cause the changes in serotonin, can cause the changes in dopamine. Lower activities of either of those are also going to put me closer to that critical line of overwhelm. A lower activity of GABA, closer to the critical line of overwhelm because I'm already tense, I'm already feeling stressed. Higher levels of glutamate. Oh my goodness. If it's not already past that critical line of overwhelm, it definitely has me closer. So that, again, when that new stress comes, now I'm just falling over the edge because I'm already on that line. And as we look at their correlations with the diseases like pyroluria and autoimmunity, that association, that makes perfect sense, because as we look at different times at which that would be coming online, the pyroluria coming online, possibly as early as 9 months, when mom's zinc and B6 are wearing off. Well, then at that point, it's going to be the baby starting to experience that deficiency, that functional deficiency. Their nervous system is more reactive and sensitive all of a sudden. And that will overwhelm them because they don't have the resources like we do to say something like, hey, I'm scared, or hey, I need touch right now. They can't communicate that as well. Sometimes they can't even move well. And so they don't have the resources that we have to be able to compensate for those things, which makes them more fragile, makes them more vulnerable to then experiencing the overwhelm, because I'm being overwhelmed by my very sensitive nervous system, and my provider is just not giving enough of what I need in order to be able to respond to that. So with that, let me share with you one of the stories. And this story is so common, and that's why I want to share it. I don't want to share this story because it's unique. I want to share this story because it is so incredibly common with people that I meet. Now, this is Laura Bautista, and she is a practitioner in my training program. And she came to me because she had an autoimmune disease by her early 20s. Yet she grew up in a very good family. And so, like me, knowing that autoimmunity is related to adverse childhood experiences, she didn't understand her health symptoms. She didn't understand her reactivity in relationships. She didn't understand her avoidance in relationships. She didn't understand. And so she started studying the somatic piece, and now she's learned the biology piece. And one of the biology pieces in that we do, even for adults, but definitely for kids still, is that we have these biochemical imbalances at the heart of what forms attachment trauma. So that if a baby and they are being exposed to high levels of folate from their mom during pregnancy, and it's changing their epigenetics and it's giving them an undermethylation status, and they are the ones that it's creating the low activity in serotonin and dopamine. What you may not know, but I know in depth because of my study of attachment and bonding, dopamine is essential for attachment. If we don't get enough of that dopamine in our early pre-verbal life experiences with our primary caregiver, we then have this low dopamine activity, and it sets us up for being more addicted to substances, because we're now looking for something outside of us to give us a dopamine hit without realizing that everyone else gets a dopamine hit from relating to other people, from being in relationships, to looking in someone's eyes and smiling at them and having that moment of connection. And woo, for those two people, there's your dopamine. But for them, if they didn't get that in their early life because they already had low dopamine activity and it just wasn't enough what their parent was providing them for touch and attunement and that bonding, well, then now they're set up for life with an insecure attachment, partly contributed to by the undermethylation status. But I mentioned the pyroluria, I mentioned the copper excess. Depending on what age those are coming into play, they will significantly affect a child's neurodevelopment. So as they're starting to walk, as they're starting to crawl, as they're starting to learn things, how well are they going to learn things if they have low GABA activity? They're not. They're going to have a hard time focusing. They're already going to be in overwhelm. And we do not learn anything when we are in overwhelm. What if they have the copper excess? It's not just the high behaviors and the emotional meltdowns that we see. They're also experiencing more trauma responses, starting to form the neuroplasticity that this is how they will always be, even after we can correct a biochemical imbalance. So these are really important, which is why then when I move to repair, whether again, I'm working with a child for attachment, or I'm working with an adult who may or may not have attachment issues, but for whatever trauma reactions that they're trying to change in their life, this is what I'm working on. I am working on being able to integrate all of the pieces that they will need, and what other therapists and the trauma therapists don't understand is how important the biology piece is. So they're not doing the biology piece at all. They're when we send a person to therapy because they could benefit from it, we have to remember that they're not hearing the biology piece and what biology is going to keep a person stuck, simply because, like copper excess, it's creating excess adrenaline. And there's no way that we can effectively change our stress and trauma responses at an emotional level when we still have them being fueled by adrenaline. So this is what I do, which is why then I have my lens, and my lens is being able to say, once I recognize that people have stored trauma, then that allows me to identify which would be the best repair tools. So my lens, and I'll share that with you right now because maybe that will be helpful, is looking for the trauma patterns first. Do I recognize trauma patterns? Do I hear them saying words like, I feel overwhelmed in my life. This all feels like too much. I don't want to get up in the morning because I'm already afraid or overwhelmed by my day that hasn't started. I just want people to go away because I'm tired. I'm tired of people. I'm tired of life. I'm tired of problems. All of that describes what it feels like to be in a chronic trauma state. So once I've recognized that, step one is recognize it. Now I'm going to look for the underlying reasons. I'm going to look for our biochemical imbalances, one of the underlying reasons that are continuing to drive that trauma state. And if so, well, then guess what one of my repair tools is? One of my repair tools is going to be addressing the biochemical imbalances, addressing the oxidative stress that the biochemical imbalances is creating. That's a big one. Oxidative stress significantly decreases our homeostatic capacity. And brain inflammation is the other very high level, and one of the first things that I find that I need to address in people in order to get them out of a chronic trauma state. Because when the nervous system is surrounded by inflammation, the cues of danger are so loud that no cues of safety can even be heard. So these three are often where I'm starting. There's a long list, and I spared you from all of them. There is a long list, but these are often the place where I'm starting because of how important they are, that they will hold a person back in their trauma state, in their trauma biology, in their trauma reactions, because of the changes and the effect that they have on our mitochondria and homeostatic capacity. So repair tools, this is a big thing that I do. I have put together a guide on the 15 easy, practical biology of trauma repair tools in case you are interested in seeing what else do I have on that list. And what are the tools? For example, you may not know the tools for brain inflammation. Those might be important for you, especially if you're working with people with biochemical imbalances. Many of them also have such high glutamate that there is brain inflammation. So knowing these tools and knowing how you can really align with someone to be able to actually help them with their trauma responses. Working with trauma responses is not all emotional. It is just as much biological and physiological. And that's where we as the practitioners have a lot that we can do to help someone. So with that, if you would like more resources as well, I do have a podcast on the biology of trauma where I have a couple episodes published with Dr. Walsh, and I look forward to taking some questions and being able to hear how this has landed for people.
Thank you so much, Dr. Aimie. That tool, or the resource tool, is going to be really great for this list. And that was an amazing presentation.
It is scratching the surface,
Yeah.
but knowing the science knowing the science of actually what is the difference between stress and trauma as the body experiences it allows us to just do so much more with intention and precision with helping our patients.
So thanks so much for your presentation, and we're going to get to the live Q&A.
Wonderful. Thank you so much.
Can you speak to how undermethylation affects trauma?
The first answer that comes to mind for me is that undermethylation causes trauma. So when you see the equation for trauma that I shared, where it's trauma happens in the gap, and trauma happens in that gap when the danger in my life feels so much bigger than my available resources. And I'm talking about internal resources like neurotransmitters, like mitochondria, and I'm talking about external resources like people and a felt sense of support, rest. And when we look at the effects that undermethylation has on our biology, we realize that undermethylation is going to be decreasing our available resources after a certain point. Initially, that's not what undermethylators often find, because being that they are competitive, they are driven, there's a lot of the histamine that's driving adrenaline. And they love it because they can be so much more productive. They can be so much more focused. They love that superhuman skill that others don't seem to have that they can tap into. But the body can only sustain that for so long. And since most people don't know how to complete those responses, let alone undermethylators who then just want to keep going and never stop and rest and have those cycles of recovery, then that's when the body starts accumulating things like oxidative stress. It starts accumulating mitochondrial toxins because it's always in that state of go, 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 and never in that, no, I'm truly in parasympathetic where I can let my body now clear out the toxins. And so this is why I think so many undermethylators do great until their third decade of life, maybe their fourth, and then they start having health issues and they start having burnout and they start having crashes because their body just cannot operate at that level of competitive driven adrenaline, and there not be consequences later on by simply the accumulation of the effects on our biology. So in that sense, I see undermethylation as a predisposing factor to trauma. Now, you add into the mix some real trauma. Why don't we throw some childhood abuse or some neglect or just feeling disconnected, whatever you want to throw into the mix. And now, whoa, how is an undermethylation system going to be able to respond to that trauma? Not very well. They're not going to have an easy time feeling their body because their body is always so restless inside because of the high glutamate and the high histamine that it's so uncomfortable to actually feel my body as an undermethylator. So why would I want to do that when I also now feel the shame and the hopelessness and all of that comes with trauma? So in this sense, like it starts to become this really vicious cycle for undermethylators where it contributed to the initial experience of feeling overwhelmed. And now it feeds on itself so that trauma begets more problems and the undermethylation just contributes to more trauma responses.
That was a great answer, Dr. Aimie. Does it matter when you have a patient in front of you, does it matter if you start with the somatic side of things or cell health, and how do you choose? It's a loaded question. I'm sorry.
I think it does matter. And this has been my entire practice that I've been experimenting with this. And I started in surgery. I started in general surgery. And after 4 years of general surgery, I realized that that was not my place because there is no place for somatic healing. There is no place for any of these trauma therapy modalities, if you want to call them that. And yet that's what they need. That's what these people need in order to fully be able to recover and heal and thrive and do well. And that's when I decided to move and switch into preventive medicine, which is all about chronic health. And all of those people need these modalities. And then I went into addiction medicine, and all of them need these modalities, all of them. So then I really started piecing together the sequence. Where do I start? What's the best way to start? Where's my entry point? Do I do this first? Do I do that first? And that became what I started experimenting around, both with myself and my patients. And what I discovered was that creating that inner sense of safety is the most important step that I can do for someone. What does that mean? That means that in 2 minutes, I want someone to be able to create a felt sense of inner safety for themselves. Cell support is not going to do that in 2 minutes. I can go take a supplement, but that's not going to give me a response to that degree in 2 minutes. I need to be able to do something now, and I need to have my patients be able to do something now in the moment when I'm feeling overwhelmed, when I'm getting triggered. And so that's why for me, I starting with the somatic work, and the results were absolutely amazing, that now it's clear to me that that is where I start. And I start in such a way that I'm only doing enough to have them ready for the other stuff. I'm not doing 1 year or 2 years, or let's do 4 years of therapy with just somatic work, and then we'll be ready for the biology. I am doing just enough. That's 21 days for me. I am doing just enough that they can learn how to shift their state of their nervous system within 2 minutes. Once they've learned that, okay, now we're ready. Now let's talk about a supplement protocol, because you're actually going to need those same skills when I start you on the supplement protocol. Now, I will add that I have started to do research and study the people who are doing this 21 days with me. And if I add in magnesium, which is one of my favorite supplements to start off someone who's had chronic stress and trauma, if I just add in magnesium, I haven't done any labs yet, I haven't talked to them about any biology stuff, but I just add in some magnesium, does it make a difference? And the answer is yes. So my studies, my numbers are showing that the change that they experience in their physical health with these 21 days of somatic interventions, these different somatic exercises, the change is greater when they also start taking magnesium. Wow. It makes sense to me. And so I'm going to keep doing research and studying people to figure out, well, what if we do this? What if we add this? What if we do a little bit of this? But the short answer is that creating that inner sense of safety, a felt sense of safety, is the most important thing to start off with. And then the body is actually more receptive to our protocols and to the supplements. Until then, the body can be so guarded, so protective, that it's resistant and reactive to everything that we try.
Yeah, that was a great answer. You guys, I'm sure you can probably tell Dr. Aimie is brilliant, and she's a leading researcher in this stuff. And I have a rumor that she may have just completed a book. So you should definitely check out that resource. So, is undermethylation, pyroluria, and copper excess in one person always a sign for trauma, or could it be just a biological imbalance?
What a great question. And this is a great opportunity for me to clarify what I mean by trauma. A trauma for me means that anything that for any reason overwhelmed me. And if I have a number of biochemical imbalances and I'm going through my normal, regular life, it doesn't matter. I'm going to be overwhelmed just by normal life if I've got 3 biochemical imbalances that are creating imbalance internally. And so when I talk about trauma, I'm talking about what happens inside of us, not what happens outside of us. It's a response. It's a physiological response that is a changing of the states of my nervous system inside of me. So I like to more phrase it as, do I have a trauma response, rather than, is this trauma? Because when I ask that question, for most people, it still sounds like we're talking about an event that happens inside or outside of us, rather than what is happening in my nervous system inside of me. And we can have trauma responses all the time, and there's nothing happening outside of us. Everything outside of us is fine. Everything outside of us is normal, is stable, but that's not what's happening inside of me. So it's what is the physiology that's happening inside of me that determines a trauma. So back to the question then, The answer is yes. When I had all three biochemical imbalances, there were so many trauma responses happening on a daily amount because of the overwhelm that my body was experiencing, just trying to get through life and work as a person with three biochemical imbalances.
Karen is asking in the chat, curious how to support a 5-year-old born prematurely during the pandemic, no physical touch for 7 days. The boy is currently overattached to the dad. And then I had a question submitted ahead of time from Annalise. She has a patient who talks for hours about past facts and events, and she's wondering if you have any recommendations to support this presentation of trauma.
Great questions. And I smile because I know that I'm in a room of practitioners.
Yep.
And so I can speak to you in a way that I wouldn't speak to my patients. So know that, right? Like I'm going to speak to you in a way that I would never, ever speak to a patient of mine who was in that place. So much of what happens in a person's biology and physiology is some of that rumination on the story. And it can be from a number of reasons. One of them just being the brain inflammation, but also they can be an undermethylator and it presents as OCD and they've got this rumination about their story that they can't seem to let go. So when I'm looking at someone, I don't care what their story is. And in fact, I'm going to share with you that I don't even ask their story. I am looking for their history and what can I tell from their history and their symptoms that would give me indications about brain inflammation, that would give me indications about biochemical imbalances? Because if those are present, I want to start with those. Those will always stand in the way, always. And there's no forward progress that I'm going to be that successful with until I address those, which I use the word support those, until I support those. So then we have someone who is in their story, and it doesn't matter why they're in their story, whether is this a personality thing or is this a biochemical thing? It doesn't matter. They're in their story. And so as I'm looking at their biochemistry, because I'm always going to assume first that it is something in their biology and physiology that is driving that. In the meantime, I've also got to get them out of the story, because every time they repeat that story, they're reliving that story.
Yikes.
And I find a way to tell them that in the most loving way. I had someone share this with me. It was 2 years ago that I had this conversation with her. And now she's made it her own and she shared it with me just a few days ago. And she was sitting with me and she was telling me again of how hard and awful it had been to have her husband die. And she felt so alone. She felt lost, all of that stuff. And at the time, I lovingly said something along the lines of, I found that the more times that I repeat a story, the more times I'm still just living in that story. And she looked at me with this shocked face. And she's like, you mean, I thought you were a trauma person. Don't you listen to stories? And I was like, actually, when people come through my programs, I don't let them share any story because it's not the time yet. I need them to have skills to be able to stay in the present moment before we are ever ready for story. And that doesn't happen for a while. And she joked with me at the time. She's like, how can you be my friend? Because I've always told stories. I'm like, I know. So she found me the other day and she says, it has changed my life. It has changed my life to no longer tell my story. And in fact, I had someone come to me the other day and she wanted to tell me her story. And here's what I told her. I said, I want you to just consider that may be the last time that you ever have to retell your story. You're not your story. So there are different ways in which we can help people, inspire them to get out of their story. And that's where the beauty of the somatic work comes for me, because until I teach them how to just drop into their body and feel their body, that's all they know how to do. They only know how to retell their story because that's what they've been taught to do. So that would be another reason why starting with the somatic work is so incredibly helpful for me as the practitioner, because then whenever I start to hear a story, I can be like, and where are you feeling that in your body? And what's going on in your body right now? And it allows me to naturally pull them out of that vortex that just cycles them down and redirect and stay in the present moment and stay out of that overwhelm and re-experiencing the emotions of that story all over again.
Yeah. And when you say somatic work, are there specific techniques you're doing? It sounds like you're doing a little bit of brain retraining there and like reaffirming and reframing. But somebody had that question in the chat of what do you mean? I'm sure that's different for different therapists.
Some people would call what I do brain retraining. It is not just brain retraining, because actually the brain, I mean, depending on what region of the brain, but the brain is more known as the central nervous system. And we are actually working more with the autonomic nervous system, that part of our nervous system that determines our neuroception, which is our perception of how safe am I or how dangerous am I. That doesn't get processed by the brain. That actually doesn't get processed by the brain. That gets processed by our autonomic nervous system, collecting all the information from inside of us and outside of us. And then it delivers that information to our brain. So many people would call what I do brain retraining, but it is so much more. It would be brain and body retraining. There are so many people that relate to our body having a message for us, our body telling the truth, our body keeping the score. And it's not ever going to be enough to just do brain retraining. We've actually got to work with our body. So the somatic therapy modalities that I've been trained in include somatic experiencing, neuroaffective touch, a few others. And I've combined those because at the time of those trainings, I was still learning this for myself. And so I put together my little exercises, if you want to call them that. They're very simple, they're very short, but they worked so well for me for being able to learn how to stay present, not escape in my mind to places, but actually stay present, be able to be in my body, be able to get out of my story, get out of my thoughts, get out of analyzing absolutely everything. And that's what I teach. So that's why I call them somatic exercises. I'll call them somatic interventions sometimes, because they are very short, sweet. They involve some form of movement, touch, because I'm working with the autonomic nervous system and the body in order to immediately shift the state of our nervous system.
Wow. I'm going to get into some nitty-gritty lab testing questions because we're getting a bunch come in. So all you nerds that are still here we go. Can you maintain a normal range of free copper level if ceruloplasmin is chronically low? And is copper excess really excess, or is it that it cannot be loaded into ceruloplasmin due to deficiencies?
There is so much that we do not know.
Good answer.
At the end of the day, we do our best with what we are presented with. And as the practitioner, when we're working with a patient, we see how they respond to different things and then have to personalize it to them and their body. So for some patients, when we give them metallothionein, for example, that may fix their low ceruloplasmin and their copper is fine. And for others, not. And we've got to figure out, well, then why would they have chronically low ceruloplasmin? What's keeping it low? And what is the solution? And I find that my patients are always what drive me to learn more, because I find someone who's not responding the way that everyone else responded. And why might that be? And that's the beauty of being able to go on these, I want to call them journeys with our patients, to be like, I don't know, but I'm going to help figure it out with you. And let's try this. And here's how we're going to track that. And then we'll try this. And that way they still remain trusting you as their guide, because you're not coming in saying that you know everything and then making it their fault when their body doesn't respond the way that you think it should. But being able to come in and use the science that we do know to make our best conclusion about what might be happening. And then from there, we have to test and track.
Yeah, good answer. Are you ever using the HTMA test for these vitamins and minerals, or are you always relying on blood?
No, I am not always relying on blood. Um, there's a lot that I can rely on symptoms. Thankfully, we have so much science now on what specific deficiencies look like and what symptom constellations that show up. And so we can have a high suspicion. And then I am looking for tests that will tell me the information that I'm looking for. And what is the best way to test that? What is the best way to get accurate data? That's what I'm always asking. So even if I am testing blood for the minerals and for the vitamins, I'm also really wanting to look at the intracellular levels. And so that's not just, the extracellular blood that I'm testing. I'm wanting to look at inside. And so that usually means spinning down the red blood cells and testing inside the red blood cells. And that's where I can get a lot of information about, well, their magnesium level says it's fine, but when I look at inside of the cell, it actually shows a functional deficiency. Or same thing with their zinc. Their blood levels seem fine, but when I test inside that cell, for some reason, zinc is not getting in. So we're going to start you on zinc, even though your blood levels are technically fine. And we're not going to stop there. We're going to figure out, why are your cells not able to take in zinc? If your blood levels are fine, it should be getting into your cells. I wonder if that means you have inflammation. I wonder if that means you have a ton of oxidative stress. So it allows me to go deeper and find what is the reason behind the different lab values when I'm able to test different forms of the values.
Yeah, so there were a couple questions about oxidative stress. What are your best practices in that situation when you're like, oh, if there's, this homocysteine is up, we have a lot of indicators of high oxidative stress. What do you do?
I have to admit that I am one of those practitioners who thinks that everyone should just always be on antioxidants. I don't care what your lab values are.
I agree. I'm with you 100%.
It should be on our water supply. That's what our food should be fortified with, not folate. It should be fortified with antioxidants, and everyone should just be on antioxidants. I don't need to test you to know that you need to be on antioxidants. But when I'm looking at anyone who has chronic stress, who is living with a lot of adrenaline, who is in overwhelm, I know that I've got to take that oxidative stress support to the next level and as quickly as possible. And so I am using everything that they can tolerate. And that's also a process of testing. So even testing down to, can they tolerate supplements, capsules, or do I need to make it a liquid? Okay, if it's a liquid, well, then I'm looking at something like C60 as a liquid, because that's a powerful antioxidant that I can get in them, that is easier for their body to tolerate until their body is in a better place, and then it can take capsules better. Okay, now let's really start with all of the other ones. But you can even find vitamin D, vitamin A. You can find a lot of these antioxidants in liquid form. And for some people, that may be where they need to start. And if their body is less tolerant of capsules, to me, that's even a higher reason and suspicion for them needing more antioxidants. And so I'm really coming in strong with antioxidants from the very beginning.
Yeah, I think you're right. We all need a lot more of that given the world that we live in.
Well, yeah, I mean, even right, like I just saw you in Scottsdale, Arizona, which meant that I had to take a flight, and just the exposure to the radiation from a flight. We live in a world where there's oxidative stress, and to think that the other forms of stress, the emotional stress, the psychological stress, isn't also contributing to that. Like, we live in such an environment where more than ever we need antioxidants to be able to thrive and do well.
I agree. You can't get away from it.
Nope.
sadly. We have a really good question about the Walsh protocol. Does the Walsh protocol for mood disorder require a specific diet? And I'm wondering why it triggers carbohydrate cravings in some individuals. I had actually a couple questions about the carbohydrate cravings. I'm curious for that for myself.
Hmm. Is there a specific diet for the Walsh protocol? I would say no. And the reason is that I'm thinking of several individuals who've come through my programs. They've had a health coaching session and they have had a full range of diets, everything from vegan to carnivore, everything in between. So for some people, I think that they naturally gravitate towards a certain type of diet. We do know that there are dietary preferences or maybe diets in which some of the biochemical imbalances will do better on. For example, like the undermethylators, I have never still met an undermethylator or worked with an undermethylator who did not do and feel better on a higher protein diet. So for those are the kinds of things that we can take into mind. But when we think of copper excess, and we know that the copper excess is creating excess adrenaline, knowing the effect of adrenaline on our metabolism, on our mitochondria, it is going to be harder to, run off of anything other than simple carbs. And so the carb cravings will be more. I would also say for the pyroluria. And the reason for the pyroluria, at least in my experience, so many of my patients in the addiction world had pyroluria and they had developed their substance use as just a means to cope with the sensory overstimulation that they experienced from lights and sounds and touch, and they weren't even aware of it. They were just numbing it. And with that, carbohydrates, sugars are actually a great way to numb our body. Sugars bind to the opiate receptors in our body, and it literally will help numb both physical pain, emotional pain. And so anytime that we're experiencing those uncomfortable sensations from our body, there will be that tendency for our brain, if it's ever engaged in any emotional eating, to remember that and to say, I know what would be a quick fix. I know what would help. And in order to try to help, it creates cravings, and we find ourselves foraging for carbohydrates in the closet, trying to hide from everyone else.
I've done it.
Yep.
Doug is asking, have you found vagal nerve stimulators helpful? V relief, pulsetto, etc. Breath work, Wim Hof. What have you found helpful, Dr. Aimie?
Hi, Doug. Good to see you here. What have I found helpful? This is one of those yes and questions that I get to answer. There is a reason why I have kind of simplified what I teach and what I lead people through, because of all the things that I've done and all the things that I've tried. These are the things that are essential. Somatic work for connecting with the body, the parts work for reframing our thoughts and beliefs and stories about ourselves, and the biology. Those are your three essentials. Without one of those, anyone's forward progress in recovering from trauma or overwhelm is going to be blocked. So then I look at these other things. I'm like, well, then where do they fit in? And some of them are helpful for different people at different times. But the point is, are you connecting with your body and aligning with your body? So many people that I've seen are doing breath work in a way that they've been taught to force their breath rather than to listen to their body and say, body, what do you want to do right now? And while that can create some incredible experiences for some people, is it helping them connect with their body? For some, yes. For many, no. And to take someone, even meditation, right? To take someone who hates to be in their body. And we have these people. In fact, it's one of the biochemical imbalances, right? Like We like to be existential and spiritual rather than actually be in our body. So for those people, they love meditation. Why? Because they get to use their mind and meditate and actually leave their body even further behind. They're not using meditation to actually feel into their body, feel those sensations. And that is an essential component to the healing journey. So I look at it in an individual way in terms of what are you using this for and how are you using it? Are you using the Wim Hof in order to push your body to the limits? Well, you're probably an undermethylator and you need to go get treated for that. And right, is that really helpful? No, it's not helpful in the sense that we are trying to push our body beyond what it is able to tolerate in terms of its homeostatic capacity, even an emotional homeostatic capacity. And in the process, anything that at any time in our life overwhelms our body's ability to stay present to it creates a trauma response. And I have seen many trauma responses created by people with great intentions doing ice baths, cryotherapy, Wim Hof, breath work, all of these things that for them, they're trying to push their body, but that's exactly it. They're pushing their body beyond what it actually has the homeostatic capacity to do. And whenever we do that, we actually are creating a physiological trauma response.
I'm so sad we have to let Dr. Aimie go. Dr. Aimie, is there anything that you want to add that you haven't said yet? We have 13 questions and it's hard to choose which ones to ask because they're all so good.
I have started to answer questions on social media. So if you want to find me on social media, post your question. I am starting to do a daily video that I will then post to answer questions. So for those 13 people that I didn't get to your questions, that might be an option for you. Anything else that I would want to say? Caitlin, when I think of what are the possibilities that we have ahead of us, this is such an exciting time in the world that we have the science to really make a big difference by being more intentional and actually working through a structured sequence based on science rather than just being haphazard about what we do. So I actually get really excited. I love to talk about trauma. I know that may seem weird, but would love to connect with everyone here and hope that they can come and find me somewhere where they can connect with me.
So let's all give her a huge thank you, Dr. Aimie. This means a ton to me as your friend and colleague, and we're changing the world with each other. So
thank you for what you do, Caitlin.
You're welcome. Good night, everybody. Bye, Dr. Aimie.
Bye.